El primero de ellos es el doctor, para los que no le conozcáis, el doctor Joel Paleski es profesor de Medicina y Enfermedades Infecciosas en la Universidad de San Francisco, en California. No voy a extenderme mucho en su currículum porque es muy amplio, pero es una autoridad mundial en el estudio de la patogénesis, la historia natural, la prevención y el tratamiento del cáncer anogenital en relación con el virus del papiloma humano. Es el director de la primera clínica en el mundo dedicada al estudio y prevención del cáncer anal. Y su producción científica es muy amplia, es autor de más de 350 trabajos, pero lo más importante es que muchos de ellos han cambiado radicalmente la forma en la que entendemos la historia natural, la patogénesis y sobre todo la prevención y el tratamiento del cáncer anal en las personas, sobre todo infectadas por el virus del papiloma humano. Dr. Paleski, it's my pleasure to introduce you at our National Congress. The podium is yours.
Thank you so much, Dr. Perez and Dr. Blanco, for the kind invitation and introduction. I've been here a few times in the last few months, and there it goes. And it's always an enormous pleasure to be here with wonderful colleagues. I was commenting earlier that I do believe at this point that Spain is the leading country in Europe with respect to doing research and implementing programs for the prevention of anal cancer, which is the title of my topic this morning. These are my disclosures. And what I'd like to do this morning is to discuss the risk of anal cancer in different groups, to understand primary prevention. By that I mean HPV vaccination for the prevention of cancer related to HPV in people living with HIV. Also to talk about secondary prevention, which is to remove precancerous lesions amongst those who already have HPV. And here's where the ANCHOR study comes in, a randomized controlled trial to answer the question about whether treating these precancerous lesions in the anus actually has its intended effect, which is to reduce the incidence of anal cancer. And then finally, to talk about what the implications of the results are from that study for your clinical practice. So anal cancer is a cancer we don't really talk a lot about. It's not very high on the radar of most people. And one of the reasons for that is that it is a relatively uncommon cancer. As shown on this slide, the incidence is in the 2 to 3 per 100,000 range. But what's important to note, though, is that since the 1970s, it has actually been going up by about 2% per year in men and women in the general population, but particularly in women. Actually, anal cancer is more common in women in the general population. In most places, we tend to think of anal cancer as a disease of men who have sex with men, particularly those living with HIV for reasons I'll show you. But in fact, the majority of absolute number of cases of cancer come from women. So that's one thing. The other thing is we know that that risk, although relatively rare in the general population, is not evenly distributed. We know that certain groups are at particularly high risk of anal cancer, and they're shown on this slide. A nice meta-analysis from IARC showing that the three groups of the highest risk on the left are all associated with HIV. Men who have sex with men, men who are not MSM, and women, all at increased risk. You can see the numbers here are considerably higher, for instance, than what we see for cervical cancer in the general population in women. We also noticed that the incidence is highest within each group amongst those who are older. Namely, the older you are, the higher the risk. So the highest risk group of all, for example, are men who have sex with men living with HIV who are over the age of 60. You see the same age relationship with non-MSM, and you see the same thing with women. Here we see one little dot for HIV-negative MSM, and this is a bit misleading. The numbers don't look terrible there, but in fact, the numbers were not stratified by age. And if you stratify MSM data by age, you see a similar age effect. So the incidence of anal cancer amongst HIV-negative MSM is similarly at levels that we would consider to be unacceptable. Two other risk groups to mention are women who have HPV-related disease elsewhere in the anogenital tract, principally the vulva, but also the cervix, and then people who are immunosuppressed for reasons other than HIV, most notably solid organ transplant recipients. And here you see the risk goes up, but not as a function of age, but instead number of years post-transplant. Namely, it's the duration of immune suppression that appears to be important. And to some degree, that plays into the age effect in HIV also, because age is to some degree conflated with the amount of years that you've been positive for HIV. So let's talk about what to do. I think there's an imperative to do something here because the rates are unacceptably high, as I mentioned, and we have the possibility to prevent this. We have two forms of prevention. They are primary prevention, HPV vaccination, preventing getting the etiologic agent in the first place. And the second is to diagnose and treat the cancer precursor lesion for those who have not had the vaccine for whatever reason. Our model here is the cervix, and the cervix is our model for just about everything because cervical cancer and anal cancer are not identical but are very, very similar. They're similar in their association with HPV, particularly HPV-16, and they're similar in that they have a precancerous lesion called high-grade squamous intraepithelial lesions, or HSIL, which we think, when we treat, can prevent progression from that HSIL to cancer. And that is actually proven in the cervix. Let's start first with primary prevention or vaccination. Well, we now know, after years, that vaccination of women to prevent cervical cancer works. For years, we've known that it prevents acquisition of cervical HPV. We've known that it prevents development of cervical HSIL. We did not have direct evidence that it prevented cervical cancer because not enough time had passed, but now we know. These are some of the data that have been published in the last year or so, proving for the first time that in vaccinated populations, the incidence of cervical cancer is lower than unvaccinated populations. And the important thing here is that the earlier you got vaccinated, i.e. prior to onset of sexual activity ideally, the higher the reduction in cervical cancer. So for those, for instance, who got vaccinated at the age of 16 to 18 years, they didn't have as much cervical cancer reduction, presumably because of the HPV that they acquired prior to the time they were vaccinated, compared with the young women and girls who were vaccinated at the age of 12 to 13. So this was wonderful news because we know also that the vaccine is very safe. What about primary prevention of anal cancer? Well, we showed a while ago that the vaccine works in the anal canal to prevent anal HPV infection and anal HSIL as well, just like it does in the cervix. It isn't quite as good. In the cervix, it's 90% plus. In the anus, we get about 75% reduction in anal HSIL, but more than 90% reduction in anal HPV, so that was really good news. Part of the problem, though, is that if you're also focusing on trying to vaccinate young men or older men even living with HIV, there are some other questions that come up. Questions about the safety of vaccination. Does it do anything to HIV viral load or drop your CD4 level? Does the fact that you're living with HIV make your immune response muted and prevent you from mounting a good immune response? What is the relationship between current CD4 and nadir CD4 and the level of titers that people can generate? And then there's questions about how much exposure people living with HIV have from a sociosexual point of view. There may be more partners, and the more partners there are, the higher the risk of exposure. And then finally, there's issues around socioeconomic status and equity, and the fact that people living with HIV may be likelier to come from populations that have harder access to getting vaccinated in the first place. So one of the first studies to look at this actually looked at an older group of men over the age of 27. This was an ACTG study, and ultimately they found that the vaccination didn't work. It didn't prevent acquisition of HPV in the anus, and it didn't prevent development of anal HSIL. And the presumed reason for that is that by this age, most of the men in this study had already been exposed to the HPV types that were present in the vaccine. So we thought it would be more useful to look at a younger group of people to see if we could at least prove that it works in younger people. So we did a study called AMC, AIDS Malignancy Consortium 072, where we were looking at MSM living with HIV in the 16 to 26-year-old age group. Most of them were, in fact, in their early 20s. And there are two important lessons that we learned, three, in fact. Number one shown here is that if you look at the proportion of people who were already exposed to the 4 types in that vaccine, we were using at that time the quadrivalent HPV vaccine, you can see that even in this young age group, a very high proportion of young men had been exposed to HPV. For example, HPV 16, the most dangerous, almost a half had already encountered it. The second somewhat disturbing thing is that at that point, already 34% of them had biopsy-proven high-grade disease in their early 20s. So a high-grade lesion develops quickly after people get HPV. So that's not good, and I think that these may be the prototype of individuals who in the future are the ones who are likely to develop cancer if nothing is done to interfere with the HSIL. You may be asking yourself, should we now be screening all 21-year-olds? And the answer is an emphatic no, and I'll tell you why later, perhaps, if we have some time for questions. So that was one thing. The other thing is, does the vaccine actually work amongst those who had not been exposed to these HPV types, because that's where the vaccine is designed to work. And what you can see on this slide are the titers generated against the 4 types in the vaccine. The patterns that you see here in blue are amongst the people who are naive, had not seen those vaccine types. They peak after the 3rd vaccination, and then they plateau. Come down, and then they plateau, a very typical pattern. In red, we see the titers that were from people who had previously been exposed to those HPV types. So they generate the same pattern, but at higher levels. Again, very typical with what we've seen in other populations. The important point, though, is that amongst the ones who had not been exposed to HPV, they did not develop high-grade disease. A whole bunch of people who were previously exposed got high-grade lesions due to those HPV types, but none of the people who were vaccinated and who had never been exposed to those HPV types were able to develop HSIL. So the vaccine works, provided that you're giving it to people who've not yet been exposed. One other little interesting factoid is shown on this slide. It's often said that boys, particularly older boys, don't generate titers as high as girls of a similar age in response to the vaccine. And in our pivotal study of the quadrivalent vaccine in MSM and heterosexual men, what we showed was that the titers were in fact a little bit lower, for instance, for HPV 16, than we've seen in similarly aged women. When you look at the titers in AMC 072, they're half of what we saw in the heterosexual men. So the HIV positive men of the same age generated titers at half the level as the otherwise healthy heterosexual men that age. So you might think, oh, that's HIV kicking in. Actually, it's not, because in this main study, we had a subgroup of HIV negative MSM, same age as these guys, and if you look at their titers, in fact, they're the same as the HIV positive guys. So the titers being half of the healthy heterosexual young men actually seems to track more with being an MSM than it does with whether or not you're living with HIV. I don't have a ready explanation for that, but it's something we have to keep an eye on. So now let's talk about secondary prevention. So here you see the high-grade lesion. This can go on to cancer if it's left untreated. And we know that this works in the cervix. That's why women get cervical cytology, followed by colposcopy, followed by biopsy to see if they have biopsy-proven cervical HSIL, and then removal of that cervical HSIL to prevent progression to cancer. So since I've been telling you that cervical and anal cancer are so similar, it seems logical that we should just do the same thing in the anus. We should put swabs in the anus to do an anal cytology. We do not call them pap smears, by the way. I get my head chopped off by my pathologist if I ever say that. So if you call it that, it's not because you heard it from me. So why aren't we just doing it? And in fact, as you heard, we started the first clinic devoted to doing this more than 30 years ago. because we assumed it would work, and it was our approach that we wanted to do it until we were told not to because it doesn't work, rather than the converse. Because a lot of people, quite rightly to some extent, say, show me it works and then I'll start. We did this and waited to be told it doesn't work. But we still need the evidence. It's not standard of care yet, and the reason is because we didn't have the evidence that it works. So the question is, does treating anal HSIL reduce the incidence of anal cancer? There are a whole bunch of reasons why that was a legitimate question. It's difficult to treat lesions in the anus, and there are some technical reasons why it may be impossible to treat at all. So we did this study called the ANCHOR study. This is the Anal Cancer HSIL Outcomes Research Study, funded by the National Cancer Institute, one of the biggest investments, in fact, that they made in the health of people living with HIV. When I came up with the name of the study, I thought I had a better name, a simpler name, which I liked better. I just wanted to call it the Anal Screening Study. But the National Cancer Institute is not stupid. And when they thought about it a little bit, they said, yeah, haha, no way. Anyway, the results of this study were published in the New England Journal a few months ago. And here is the citation. And essentially, the kind of data that we need were a randomized controlled trial. So how do you do that? You screen people at risk, look for the lesion in question, biopsy-proven anal HSIL, and then randomize them 50-50 to monitoring, meaning no treatment, but careful follow-up, and biopsy-proven high-grade disease lesions being treated for as long as possible and getting rid of as much disease as possible. So we screened everybody with high-resolution anoscopy. It wasn't actually a screening test per se. We just needed to find out who had disease. And then if they had high-grade disease and they met the other study criteria, they were randomized and treated on the first day of randomization if they were randomized to the treatment arm. Those who didn't have biopsy-proven high-grade disease were not enrolled. Those who had cancer were not enrolled. They were sent off for cancer treatment. So essentially what we did was we randomized, followed over time, and then counted up the number of cases of cancer in both arms. We originally thought that we were going to need more than 5,000 biopsy-proven high-grade lesion cases to enroll in the study. And what I'm going to show you, in fact, was that we didn't end up enrolling that many people because the progression rates that we had modeled when we were doing our power calculations were actually higher than we originally anticipated. So we stopped the study before we actually enrolled 5,058 people. Instead, we enrolled and followed 4,446 people. To get those 4,446 people, we screened 10,723 people at 25 different sites around the United States. I thought it would be interesting to start by showing you what the data looked like because they're very sobering. So we screened those individuals, looked for high-grade disease, and what you can see here is that 53% of the men at that screening visit had a biopsy-proven high-grade lesion, at least one. 47% of the women had a high-grade lesion, and 67% of the transgender individuals had an anal high-grade lesion. So these numbers are enormous. Let me put this in context for you. If you were to sample randomly 100 women in Barcelona for cervical high-grade disease, you'd find less than 1% having a cervical high-grade lesion. So these numbers are very, very big. In addition, we found 17 individuals with asymptomatic cancer for a point prevalence of 160 per 100,000. Again, these individuals were referred immediately for treatment. I thought I'd say a little bit about the demographics of our population so you can see how they relate to your populations. Our goal was to try and get something resembling the overall US HIV population to make it at least locally generalizable. And for the most part, we were pretty successful at that. There were no differences between people in the two arms, firstly. But the important thing to know here is that the median age was 51, and people on median were out 17 years from HIV diagnosis. So these are people who'd been around for a while. In terms of their gender identity, we saw that 80% were male, 16% were female, and 3.1% were transgender. As far as race and ethnic background is concerned, again, similar to what we see in the US, about a third were non-Hispanic white, 42% were African American, about 15% were Hispanic, non-African American, and 1.3% were Asian Pacific Islanders. The one area where we differed some from the profile of the US HIV population overall was in the CDC HIV risk group, because in our study, about 80% reported same-sex activity. In the US, it's closer to about 60%, so we're overweighted a little bit in same-sex activity as a risk factor. And since this is the group that is at the highest risk of anal cancer, that might in part explain why some of our numbers are higher than what we expected in terms of prevalence of high-grade disease and progression to cancer. Interestingly, also, about a third of our population were smokers. That's higher than the general population in the US. I point it out because it's one of those risk factors that we have the opportunity to intervene with. And then as far as their HIV status is concerned, they're really quite good. Almost everybody had a low or undetectable viral load, and the median CD4 level at enrollment was over 600. So this was a group, despite their many life challenges, pretty well controlled from a HIV point of view. The last thing I want to point out here is that we stratified by two other factors. One is the nadir CD4, and what you can see on this slide is that basically a half or so of the population in both arms had a nadir below 200. And the other was the HSIL size at screening. We know from the cervix, in treating women for cervical HSIL to prevent cervical cancer, that the women who are most likely to fail are the ones with the biggest lesions. They have positive margins after a loop electroexcision procedure, and they come back and they have a chance to progress. We thought it would be important to look at lesion size in our context as well, and we picked a pretty crude measure because it's difficult to be very precise about this. We said less than or greater than 50% of the total area of the anal canal or perianal region. And here we found that about 12% in both arms met the definition of having lesions big enough to be 50% or more. So basically, when we did the power calculations, we determined that in this time to cancer event-based analysis, we would need 32 cases of anal cancer, 31 cases, pardon me. We reported to the DSMB when we had 32 cases, and we ultimately disqualified 2 because it was determined that they had developed anal cancer before they were randomized. So the final analysis was based on 30 cases, and as you can see on this slide, 9 were in the treatment arm and 21 were in the monitoring arm, for a 57% statistically significant reduction in the incidence of anal cancer. So that was good. We found 2 other things that were disturbing. One was the progression rates in the monitoring arm, again, double what we thought they were going to be, at 400 per 100,000 person years, so really quite high. And unfortunately, the progression rates were high in the treatment arm too. They were 173 per 100,000. The delta between the 2 arms is what matters here, but the 173 meant and means that we need to do better still in terms of treating these lesions to prevent progression. So this is a Kaplan-Meier showing the 2 arms of the study, the monitoring arm in blue and the treatment arm in orange, and these curves are progressively widening. And our projections are currently showing that we expect about 80% of anal cancers to be prevented in this way over time. A couple of other interesting facts. One is that over a 4-year period, the progression rate in the treatment arm was 0.9% and 1.8% in the monitoring arm. That may not sound like a very big difference, but you have to remember that the median age of our population was 51 years, and people are living normal lifespans these days. And that difference is likely to progress or even get bigger over time because of the age-associated effects. So if you multiply that delta by the number of years a person is expected to live, what it really comes down to is that nowadays we think a person has about a 10% lifetime risk of anal cancer if they don't get screened and treated. This is an awful disease. You may survive it. You may die if diagnosed too late. If it gets diagnosed early, which is most of them, you survive, but the treatment has a very severe impact on quality of life, namely the radiation-induced changes from combined chemoradiation therapy. Looking at the lesion size also, the lesion size here also seemed to be a very important factor. You can see, for instance, that people who had the bigger lesions had a progression rate of over 1,000 per 100,000, roughly 5 times higher than the progression rates from people with smaller lesions. The good news here also is that the way that we treated these lesions, which was a primarily office-based electrocautery, the technique that we use is hyfurcation, was very safe. Overall, we had only 7 study-related serious adverse events in the treatment arm and just 1 in the monitoring arm. We knew this was going to be safe because we've been doing this for years, but now we have the proof, and the impact on quality of life was really quite minimal. Again, I'm guessing that most of you are like me. You're not surgeons. I'm an infectious disease doc. Anybody in this room can do this procedure. It takes about 20 minutes to do the procedure itself in the office. Patients get up, they go to work. It's not like what you're imagining what happens when you send a patient to surgery, for example. So just thinking sort of bigger term, many of you may know that the World Health Organization is now launching a program for cervical cancer elimination. And it's based on 3 pillars: vaccination, screening and treatment of HSIL, and proper treatment of cancer, where the goals are 90% vaccination, 70% get screened at least once, 90% of people with high-grade lesions and cancer get treated. Of course, they weren't thinking about anal cancer, but I do. And given the similarities, I don't see any reason why we can't use a similar approach for anal disease, where again, in orange, the vaccination or primary prevention should make most sense in the younger ages. You want to get people before they become sexually active or as early as possible thereafter. And then as they get older, you start to move in the gray to more secondary prevention and ultimately treatment of cancer when cancer develops. So to summarize, primary prevention is HPV vaccination. I can't emphasize it enough. It's the long-term answer to preventing all HPV-related cancers. It's critical to give it early, and if you do, it will work. For secondary prevention, I've shown you that progression rates are very high from high-grade disease to cancer. And now, though, we've shown for the first time using a randomized controlled trial that we can do something about it, that we can significantly reduce the incidence of anal cancer. Of course, we still need to do better, but we can have a very substantial effect even now. And these data are being assessed by the CDC as we speak. We've suggested some revised guidelines which will make this standard of care for people living with HIV. We'll see how the final guidelines come out, but that's the plan. So as I mentioned, there is still room for improvement in the treatment of anal HSIL. I say this because if any of you are thinking about research questions, it's a very ripe area for research right now. And the other thing is, with so much HSIL, we have to figure out what to do with all these folks. It would be really important to have biomarkers of progression to cancer, so we can focus our efforts on those folks, or biomarkers of spontaneous regression, because for those individuals, we could actually back off and not spend as much of our resources on following those individuals. Again, an important research question. We need to figure out how to optimize our screening algorithms. HRA is not a screening tool. It takes a long time. It takes a long time to get trained and good at it. There's a very big shortage of people trained in HRA right now. If anybody in the room is trained in HRA, they should be treated like kings and queens. Okay? It's a very important skill right now. We need many more people. So we need to scale up training programs. That's got to happen. And then the other question is, even with the very high rates of anal cancer in people with HIV, they only contribute a small fraction of the overall actual number of cases of cancer annually. It's the other high-risk groups and people who don't fit into any of the other high-risk groups that are actually contributing most of the cases of anal cancer. and we need to figure out how to screen them and whether we can extrapolate the findings of ANCHOR to these other groups. So with that, I'm going to stop, and muchas gracias por su atención.
Thank you very much, Joel, for this excellent talk.